I think that the muscle-invasive bladder cancer is a challenging disease. And up to now, the standard of care is represented by, in case of cisplatin eligibility, the use of neoadjuvant cisplatin and then radical cystectomy, otherwise directly radical cystectomy or other radical treatments such as radiotherapy. But radical cystectomy is not a simple procedure. It is very complicated for the post-surgical management and life of our patients. So I think that in the future we should focus on preserving the bladder and selecting those patients which are good candidates for bladder-sparing approaches. There is a lot of talking about this in the scientific and the oncological community. For example, some criteria, for example, the clinical complete response has been proposed by KOLs such as Dr. Galsky. But there is a lack of consensus about this clinical complete response definition. It is clear that we can use not only the histological analysis, because of course if we want to avoid a radical cystectomy, this data is not available, but we can combine the radiological evaluation, the cystoscopic evaluation, and also the circulating cells or the more sensitive ctDNA. I think that the future trial should be designed with this focus to individuate patients who can avoid a radical cystectomy. For example, next week in my hospital in Milan, the San Raffaele Hospital, we will have a consensus with some representatives, not only from the academic side, but also from the regulatory agency side, talking about this topic, the design of future clinical trials, trying to use the bladder-sparing approach and how to select these patients. Thank you for the question. During this ESMO Asia meeting, we presented the updated interim results from the SURE-01 trial. This is a single-arm phase 2 trial using sacituzumab govitecan, an anti-TROP2 antibody drug conjugate, in patients with the CT2-T4 and 0M0 muscle-invasive bladder cancer, which were ineligible or refused also cisplatin. Patients were treated with the sacituzumab. At the beginning, we used the classical dose of 10 milligrams per kilogram, and they received 4 cycles in the neoadjuvant phase and then underwent radical cystectomy. But after the first 8 patients experiencing important treatment-related adverse events and even a grade 5 treatment-related adverse event that led to a death, we amended the protocol and reduced sacituzumab to 7.5 milligram per kilogram. We introduced the primary prophylaxis with the GCSF, and then the number of adverse events lowered and overall the grade lowered. With this, we could give radical cystectomy to 19 patients. We also had 9 patients that refused the procedure after the evidence of a clinical complete response or due to personal reason. To these patients, we offered a RETI-URBT, but included them in the efficacy analysis. And then the rate of complete responses of this patient, defined as YPT0 and 02X responses, was around 37.5%. It was a good, an interesting result. Here at ESMO Asia 2024, we also presented the first analysis of the event-free survival after 13 months of median follow-up, with a 6 months event-free survival of 87.5% and a 1-year EFS of 84.4%. First of all, we are continuing the SURE-01 trial with sacituzumab, but we have another SURE ongoing, the SURE-02, combining sacituzumab with pembrolizumab, both used in the neoadjuvant phase, and then pembrolizumab continued in the post-surgical or adjuvant phase with the inclusion of bladder sparing possibility for patients achieving a response after the neoadjuvant phase. So we will run also trial designed with the aim of selecting patients who can avoid radical cystectomy, because we believe that this is a too far complicated procedures, and the quality of life of our patients can be preserved avoiding radical cystectomy. So this will be our aim: how to select patients to avoid radical cystectomy and how to improve the pathological response rate to, as we know, to increase the survival options.